The quote on the flyer says, in medicine, accuracy saves time and precision saves lives. So how this is applicable in central line tip positioning? Let's try to find out in today's presentation from X-ray to intra-cavitary ECG, redefining accuracy in central line tip placement. Whenever we put a successful central line, what we do? We are very happy and we advise chest X-ray to see whether patient is having pneumothorax or not. We are rarely bothered about the tip of the central line. But we all know that there are many complications associated with the malposition of the central line tip. Patient can have arrhythmias, cardiac perforation and tamp node, vessel damage leading to thrombosis. This thrombosis is more relevant for central lines aimed for dialysis or chemotherapy agents. Intraoperatively, there will be inaccurate CVP measurement and central line malfunction. All these complications are seen more with the left-sided central lines than the right-sided ones. You can note here that the risk of thrombosis and catheter dysfunction is very low at the ideal position. So this is the ideal position, and the data shows the lowest rate of thrombosis, that is 1.5%, and almost 0% of catheter dysfunction. If the complication rate is so high, that is it is almost 45%, if the tip is malpositioned at the brachiocephalic vein, and this thrombosis at this location will lead to the SVC syndrome. If the complication is so high, then we should try to keep the central line tip precisely at the ideal position. So aim of my presentation is to create awareness about the novel intra-cavitary ECG for precise tip positioning of central line or the peak line or the HD catheters. So this will be the outline of my presentation. I have already discussed the complications associated with the malposition of the CVC tip. So we all know why the C tip location is important. We will see what are the guidelines related to the central line tip position, what are the current methods to confirm the CVC tip, X-ray and intracavitary ECG for CVC tip positioning, and then we will conclude. As per this Infusion Nurses Society standards published in 2016, the central venous access device tip terminate in the lower one-third of the superior vena cava near the cavo-atrial junction tip position. So these are the guidelines. Then FDA and patient safety alerts, the tip should remain outside the right atrium, above the pericardial reflection to avoid arrhythmias, cardiac wall perforation and tamp node. As per the British Committee for Standards in Hematology, they state the optimal tip position is in the distal SVC or at the SVC RA junction. So these first three guidelines, they are related to the adult patient. But you can see even in pediatric best practice guidelines published by Association of Vascular Access in 2019, the optimal tip location in pediatrics is the distal SVC or cavo-atrial junction. Now we know that in adults as well as in pediatrics, as per all the guidelines, sweet spot for central line tip is the cavo-atrial junction, which you can see, which is denoted by this red arrow. What is this cavo-atrial junction? It is nothing but the junction of superior vena cava and the right atrium. And why it is the safe area? It is the safest for the location of the central line tip. It extends from 2 cm above and 2 cm below the cavo-atrial junction. And why this cavo-atrial junction is safe? Because it is the zone of maximal blood flow. That is the first. Then the right-sided central lines will be parallel to the venous wall. And lastly, it allows possible catheter movements plus minus 2 cm due to the breathing or the position changes. Now we know the sweet spot for our central line tip. Let's see the available methods for tip positioning. So intra-procedural assessment of the tip position can be attained by several techniques such as fluoroscopy, that is X-ray, transthoracic echocardiography, transesophageal echocardiography. The most accurate intra-procedural method is transesophageal echocardiography, but obviously it is not cost effective and it needs expertise and high-end equipments. The transthoracic is also accurate, but only when the tip of the central line is located in the right atrium. And the other methods include the intra-cavitary ECG, CT, MRI, and angiography. So out of these, only ECG can be real time and it can be done during the procedure. So rest of the methods like CT, MRI, and angiography, they are only for theoretical purpose. So conventionally, we do a post-procedure chest X-ray, and this is practiced not only in India but across the globe. If C-arm is available, we can use it during the procedure as well. Now, see these X-rays. Can we tell with confidence where is the tip of the central line? In the first chest X-ray, you can trace this central line up to the cavity of the heart, but beyond that, it is not visible. And in this second chest X-ray, you can see probably it is located somewhere in the right atrium. So we are not very sure about these X-rays. And why so? Because these are the anteroposteriorly taken shoots. And second thing, patients are lying supine in the bed. So post-operatively, most of the patients are not ambulated and it is not possible to take the PA view in those patients. And in PA view only we can clearly see the central line tip. So it is very difficult to locate the central line tip in the AP shoots. So X-ray confirmation of the central line tip has many disadvantages, which include the first one is the delayed confirmation. So usually you will advise chest X-ray post procedure and it will take few hours for the X-ray to be done and another few hours till the X-ray is seen by you. Secondly, this procedure, that is X-ray, is a costly procedure in terms of time, material, and the personnel required. Then there is risk of radiation exposure to the patient as well as the staff. The next limitation is in accuracy and the interpretation. The accuracy of the tip location via chest X-ray is often perceived. So what does it mean? It means that different readers, suppose there are 5 different people viewing the same X-ray, they might read it a little bit differently and report the tip in various positions. So this variance leads to a much lower degree of sensitivity and specificity compared to the ECG or the ultrasound for confirmation of the central line tip. The list of disadvantages of the chest X-ray or the fluoroscopy is long. Next in the list is unreliable anatomical landmark. The right superior heart border is an unreliable identifier of the atriocaval junction, as the right superior border of the heart is composed of the left atrium in 38% of the patient. So these 38% are mostly normal patients. If you consider the cardiac patient, then this figure will further increase. So the catheter placed deep might appear to be in the right atrium when are they actually safely in the SVC. Then there are positional differences. The location of the tip assessed by the X-ray often differs from the position assessed intra-procedurally by the ECG. And why this mismatch is there? Because many times X-rays are performed in the standing position. We also see the movement effect, meaning in the standing position, particularly during inspiration, the central line tip appears to be in higher location compared to the supine position. And this difference could be as high as 2 to 3 centimeters. Finally, there are missed complications with the X-rays, like the small pneumothorax or the hemothorax. So it will need time to develop. And these are often missed with an immediate post-placement chest X-ray. So considering all these disadvantages of the X-ray to confirm the central line tip, the European Society of Parenteral and Enteral Nutrition has given the guidelines that this radiological control after the central venous calculation is indicated only on two occasions. And what are those two occasions? The first one is an insertion technique that entailed a risk of pneumothorax. So probably you are doing a blind procedure, you don't have access of the ultrasound, and you require few multiple pricks. So probably in those patients, the risk of pneumothorax is high and you will need chest X-ray. And the second occasion will be the tip of the catheter is not verified by other methods during the procedure. So they consider that other safe methods like the ultrasound and the ECG should be routinely used. So this intra-cavitary ECG, it redefines the accuracy in central line tip placement in real time. So let's see how it works. This intra-cavitary ECG utilizes lead 2, which magnifies the changes in the P wave and helps us for central line tip positioning in real time. There are predictable changes in the P wave morphology as the central venous catheter tip approaches and enters the right atrium. Here you can see as the central line tip approaches the proximal SVC, we can see the normal P wave. As you move towards the SVC array junction, the P wave height or the amplitude start increasing and it will be maximum at the SVC array junction, that is cavoatrial junction. As the central line tip moves towards the right atrium, you will see a negative deflection in the P wave. There are two techniques of monitoring intracavitary ECG for central line tip positioning. First technique, and the one which I use personally, is the guide wire technique. In this guide wire technique, it utilizes the metal guide wire which is provided with the central line and it is inserted in the catheter as an intracavitary electrode. It is useful for the catheters already pre-arranged for ECG. Like the Bibron is a company which provides this Certofix central lines. They have this special adapter. We will see a small video of that adapter in few seconds. And they also provide a cable to connect the guide wire with this adapter. So this guide wire is connected to the ECG cable via an alligator clip. And the most important key step in this technique is the accurately measuring the guide wire length to ensure the J tip is just at the end of the catheter. You need a special adapter for connecting guide wire of central line with the ECG monitor. So B Brown has a special device for this purpose. It is called as Certodyne adapter. This video shows how to use Certodyne adapter. This is Certodyne adapter used for intracavitary ECG monitoring. So we will see how we connect ECG to this Certodyne adapter. This is the lead which is on the right shoulder of the patient. So we will apply this RA clip here on the Certodyne adapter. Then this will be covered. The cable which is coming from the Certodyne adapter will be connected here, and now you can see ECG here. So here you can see the ECG. Here we will connect the adapter which comes with the B Brown Certofix central line, and then this is the switch to change over from the chest lead to the intracavitary ECG. Thank you. So this video gives the demo of intracavitary ECG monitoring for proper placement of the central line tip. First we will prepare this central line, 14 centimeter central line, which is having 4 lumens. So we will first connect the 3 ways. We will flush with saline and then we will mark guide wire when its tip comes out of the central line. This is the CVP or the central port. We will not connect 3-way here. I am flushing all the 3 ports. This is the guide wire. Now we will take the marking pin and the ECG adapter cable. I will show how we will use this marker pin. This is the sterile marker pin. This is the cable which comes with Certofix B Brown central line. This crocodile key is used to connect with the guide wire, and this connects with the Certodyne adapter. First, we will mark the guide wire at a point when it comes out of the central line. You can see the JTP just coming out of the central line, and here I will mark with the marker pin. Connect clip here at this point when the guide wire is coming out of the central line, and then we will connect it with the Certodyne adapter. Okay, so here I will mark with the marking pin. So here you can see the blue mark. So this is 20 centimeter mark, that is 2 marks. And here I have marked with the mark. So at this point, guide wire will come out of the central line. Again, we will confirm. The JTP is coming out of the central line, and here I have marked with the marker pin. Cable with the guide wire at a mark where J-tip just come out of the central line. Now the second is connected to the Certodyne adapter. Now I am switching from the surface ECG towards the intra-cavitary. Now this is the switch. Now I will insert the central line and I will observe the changes in the ECG. Now before we start recording the intra-cavitary ECG and changes in the P wave amplitude, please note this is the baseline ECG and the baseline P wave amplitude, so that we can note the changes in the P wave amplitude as the guide wire goes inside the SVC towards the SA node. This is the 10 centimeter mark. Already the ECG is showing the P wave amplitude which is increasing. Now this is 11 centimeter. You can see there is a rise in the P wave amplitude. Now this is 12 centimeter. You can see there is further rise. This is 13 centimeter. And this is 14 centimeter. At 14 centimeter, the P wave height is maximum. So as you saw in the previous video, gradually as the tip moves intravenously from SVC to the SVC RA junction, the P wave starts increasing. Now this is the video where you can note that the P wave amplitude can be high as R wave or it can be more than that. Just watch this small video. So this is the baseline ECG. Uppermost one is the lead 2. We have to observe the lead 2. Here you can see the P wave amplitude is normal as compared to the R wave. Now as the guide wire starts going inside the SVC towards the RA junction, you can see here the P wave amplitude has started increasing. It has further increased. Now it is almost 2/3 of the height of the R wave. Now here you can see some arrhythmias, maybe probably the guide wire is hitting the right atrial wall. And now you will notice the P wave height has further increased and it is almost equal to the height of the R wave. Here you can see the P wave amplitude and the R wave amplitude is almost same. Now here it is more than the R wave. And now you can see there are negative deflections. The P wave has positive as well as negative deflection. So such type of ECG can be noticed during the use of this intracavitary ECG. For this procedure, we need this Certodyne adapter which is not easily available. So what will you do if you don't have this Certodyne adapter? So this is an innovation from India. This is a low-cost alternative to the Certodyne adapter. The authors, Dr. Jain, used two ECG leads. So these are the two ECG leads, and they have used these ECG leads very innovatively. These two ECG leads are pressed back to back, and on one end you will use this paper clip. So this paper clip is applied on the one end. Other end you will apply the right atrial ECG lead cable, and this end of the paper clip is connected to this cable which comes with the B Brown Certofix central line. So this way there is no need of the Certodyne adapter, and you can easily monitor the intracavitary ECG. This one is another improvisation of idea from Dr. Jain. So Dr. Singh, they have used copper wire which has a higher conductivity. So instead of paper clip, the authors describe attaching the sterile copper wire. So this is the sterile copper wire. So they have attached to the one end of the chest lead, and other end they have connected the ECG cable, and this cable which comes with the Certofix central line, one end can be connected to this copper wire, another end to the central line, and you can monitor the intracavitary ECG for correct placement of the central line tip. So the second technique for this intracavitary ECG monitoring is the saline technique. It uses the column of normal saline solution contained in the distal lumen of the catheter to transmit the electrical signal. There are few papers they have described that instead of normal saline, they have used soda bicarb to flush the central line catheter, and this will conduct the electrical signal better than as compared to the normal saline. For this technique, you will need an ECG adapter or a transducer like the alpha card. I will show pictures of these various adapters in next few slides, and it is attached to the distal lumen, and an alligator clip is connected to the adapter. So this intracavitary ECG monitoring for peripherally inserted central catheters, that is for PICC lines, you need to use this saline technique because guide wire is not there in the PICC lines. So you have to do saline technique to monitor the intracavitary ECG. So this Vigon provides this Vigo card 2. So here this end connects with the PICC line. From here you can inject the saline, and other end is connected to the chest lead. This is another Arrow Jones ECG adapter, and probably this one is produced by the B Brown, where this end gets connected with the PICC line. From here you can inject the saline through this syringe, and other end similarly connects to the Certodyne adapter. So intracavitary ECG has many potential advantages. It is effective, inexpensive, safe, easy to perform, easy to teach, and easy to learn. So these are the advantages of intracavitary ECG monitoring for placement of central line tip. But there are few limitations. The only major limitation of this method is that it can be applied only when P wave is evident on the basal ECG. You cannot use this method if there is severe tachycardia and you cannot appreciate the P wave in patients of atrial fibrillation and in those patients who have pacemaker. But now there are few publications where they have successfully utilized this method in patients who have atrial fibrillation, and they have shown that these atrial fibrillation waves, they increase in the amplitude, and that can be utilized for the correct placement of the central line tip. So this is a paper published in Journal of Vascular Access 2012. This is a multi-center trial. They have included 1444 adult cases across 8 centers, and they have assessed ECG guided tip placement in various devices like the PICC line, dialysis catheter, and the ports. Their results are very fantastic. This technique is feasible in 99.3% of insertion with no procedure related complication. That is very important. The tip position on post procedure X-ray was exactly at the intended target in 83% of the cases. In another 12% of the patients, the tip position was within 1 to 3 centimeter as expected, and only 3.8% positions were significantly malpositioned. So this intravascular ECG guidance is highly accurate and safe for real-time tip location across all catheter types. So to conclude, intracavitary ECG provides a real-time assessment of tip of central line. It is safe, reliable, and effective method. The post-procedure chest X-ray is recommended only when you suspect pneumothorax. So we have to learn this new technique so that there will be fewer complications and there will not be any need of chest X-ray unless you suspect a pneumothorax. So thank you for your patient listening.